to the kickoff of our RPC retreat, which has been disrupted in the past couple of years by COVID and sometimes at the last minute, and also by our Royal College review last year. Now, having the Royal College review behind us, I thought that gave us the opportunity to do something different at our retreat this year. And instead of reviewing APAs, CBD, goals and objectives, so it's going to be a little bit different than we usually have, okay? As we're all aware, AI has rapidly creeped into all facets of our life, including our research, our clinical, and our medical education. There was an article just last week in Medscape entitled, "Will AI Replace Cardiologists and Turn Them into Managers?" One of our med schools recently asked applicants to write an answer to this question. In your opinion, what values, ethical and societal, should be considered when developing AI algorithms for assessing applicants for medical school? In fact, program directors have talked about the CARMS applications and is there value actually in having the personal letter? How do we know it's not AI generated? Okay, our patients are also using these AI tools and will be using them more in the future. And this can result in conflicts between the advice they get from their physicians and what AI gives them. So how do we deal with those discrepancies? There's multiple tools out there, there's multiple developers. Are there guidelines and governance with respect to reliable AI and reliable people who develop AI? How do we help them choose those reliable platforms? The Royal College has already produced an AI task force on artificial intelligence and emerging technologies, and we are fortunate to have one of the members of that task force with us this morning, Dr. Tanya Horsley. Dr. Horsley is the Associate Director of Research and Evaluation at the Royal College and faculty of and she's faculty at the School of Epidemiology and Public Health at the University of Ottawa and teaches evidence synthesis. At the rounds this morning, Dr. Horsley is going to tell us a little bit about that task force and the guidance of the Royal College and recommendations with respect to the impact of AI on medical practice and education. And if AI will be incorporated into the Royal College CanMeds framework and possibly even get its own petal on the, on the AI flower. Okay, we're also delighted to have Dr. Devin Singh with us today. Dr. Singh is a practicing pediatric emergency medicine physician at Sick Kids in Toronto. His research focuses on machine learning to solve some of the healthcare's largest problems, and we have a few of them. He is the physician lead for artificial intelligence and machine learning at Sick Kids. He is an assistant professor in the Faculty of Medicine and Division of Computer Science at U of T. He has recently founded an AI platform entitled Hero AI. He's going to tell us a little bit about this morning and where AI platforms can be helpful and where we should be cautious and have concerns. He teaches, I think he teaches a course to trainees on this. So we're looking forward to delving a little bit more into this at our retreat and being able to optimally use these platforms and stay out of the weeds when it comes to risks. So without further ado, Dr. Horsley is going to start us off.
Thank you so much for that. I want to make sure the sound is on. That was a great introduction. I can assure you cardiology is you're not going to be turned into managers, and that's not the vision of the Royal College. And I'm just really grateful to Dr. Kavanagh for the invitation and the chance to speak on this. I feel like the really boring opening act to the Bruce Springsteen of AI. I'm talking about the task force, but I feel very privileged. Devin and I have been doing a bit of a road show together on a few things, and we really complement each other in terms of our perspectives. There we go. So this is the Royal College. You probably have PTSD from doing an exam there. I put this up and some people go, oh my God, that's the place. It is a lovely place when you come back. Hopefully you will volunteer in future at some point and be on a committee. But I do want to say that in the spirit of reconciliation, I acknowledge and am grateful to have the opportunity to present today on the traditional territories of the Blackfoot Confederacy, the Tsuut'ina, the Nakota Nations, the Métis Nation, Region 3, and all the people who make their homes in the Treaty 7 region of southern Alberta. Now, when Catherine reached out and asked about the task force, it wasn't just about the perspectives of the Royal College. It was sort of the perspectives generally around the experts that we worked with. And when we started our journey in 2018 on this task force, which now seems like miles away, we had the chance to work with a gentleman named Dr. Bertalan Mesko. He's considered the medical futurist. He's the director of the Medical Futurist Institute in Hungary. And what he does all day is he analyzes how science fiction technologies can become a reality in medicine and healthcare. He's a self-proclaimed geek physician with a PhD in genomics, and he's an Amazon top 10 author. And this is what he predicted in 2019 that we would see. He says, when I arrived to my physician saying that, look, I measured most of my vital signs and health parameters I got my genome sequenced. He actually did. I used an advanced algorithm in the cloud to get some meaningful outcomes of it, but I can't deal with this alone. This puts physicians in a new situation where they have to deal with an immense amount of data, and they will need new skills and knowledge that they don't get currently in medical education. So this is our clarion call that we really need to think deeply at the Royal College around how do we support and train physicians in the future. So some people ask me, Tanya, why a task force? I don't get it. I've not really understood why the college took up this particular framework. And the truth is the recognition was we didn't have the expertise in-house. So task force typically bring together a group of experts that was led by Dr. Richard Resnick, who at the time was the Dean of Medicine at Queen's and is now our past president, and a whole host of individuals. We came together really to think deeply and opine about what was going on in the landscape, particularly in Canada, and of course, specifically in specialty medicine and training, to really think about what is the strategy going forward and what does that pathway look like in terms of development as an organization. If you're in AI in any way, shape, or form, you may recognize some of these faces. Omar Zaini is pedigree is here in Alberta. He was amazing as a contributor to this. But this really was that blue ribbon panel that came together and spent hundreds, if not thousands of hours thinking about the future direction of the Royal College and around trainees and those in practice already. When I talk about the task force and AI, just a little comment on the scope. We conceptualized AI and emerging digital technologies as those that, of course, intersect with medicine. They include machine learning, augmented reality, virtual reality, et cetera. And of course, the big question here is ChatGPT, generative AI, does not even appear in our task force report. So the productivity of this as a field certainly has given us pause to think about how do we stay current with the rapidity of change in the environment. So a little background on what went into the task force, hundreds, if not thousands of hours. We did a very deep dive, an annotated bibliography of what we thought were the current reports on AI from sister organizations, international institutions. And at the time, we're about 24. I would say there's likely more now. We did a fellow and resident survey to get perspectives, just where are you at? How do you feel in terms of the support you're provided? Are you confident in your knowledge around AI? And I think I'll be presenting that more deeply at the retreat today. And then I think the most impactful and I think privileged opportunity that we had was really to interview key informants. These were honestly the top minds in AI at the time, and they still are currently. 30-minute interviews, scripted, and the ability to really look at and pore over hundreds of pages of text and insights from these experts at the time. So I won't have time. I was told 20 minutes for me, 20 minutes for Devin. I won't be able to go into every recommendation, but here are the top ones. So this came out a little bit from Catherine's introduction, and the health of specialties, the risk to specialties. I think at the time, Radiology was under threat. Radiologists had come together to really write a piece around the health of radiology, and that the more that they learned about radiology, the more they realized that they would have a job. It would just look different. And so what we have said is that AI will not replace doctors. Doctors won't use, that don't use AI will be replaced. But at this time, the Royal College really has no intention to make alterations to the number and complement of specialists being trained, and that we really will monitor the impact of AI. And I think that recommendation still stands. Cardiologists will not be managers. It just might look different. This is a controversial slide. For those of you online, please don't tweet this. Richard Resnick took the liberty, who am I to say no, of adding a pedal to our framework. And this is, you can be tongue in cheek and sort of cute about this, but the truth is, undergirding this slide is the recognition that digital literacy is going to be not only but probably the competency going forward when we talk about AI. And so digital health literacy companies are in fact being integrated. There's a working group that's looking deeply at this, and whether or not it's its own pedal or across all of the pedals is conceptually something that's being worked on. Now, this one is an interesting one, and there was a recommendation to consider introducing a new discipline in clinical informatics. And why did this emerge? Dr. Resnick, if you've heard him present on this, is that he was at sort of Google in this sort of AI division and met a young physician who had just completed her training. And he said, you're here working. Why didn't you go into clinical medicine? She said, not only did I not go in, but a third of my Stanford class went straight from training into industry. And so the idea that we have to really think deeply about the impacts and the intersection and what we want in our field, I think is something the task force opined on and thought about deeply. And I just want to give a quick nod to Devin. He really is the phenotype we're looking for. Devin, I will embarrass him a little bit, but did the heavy lifting, did the extra degree on the side, really built up his competencies, and the college has not provided a framework for that yet. And so thinking about how do we create more of these phenotypes across the country who can be leaders in their institutions, I think is an area of great promise for the college and a commitment that we're having going forward. So Devin and I joked a little bit about whether or not they were doing surgery on a gallbladder here. I'm not one to say that. But the idea is that you would not have this chronicity of your career going forward. The idea of micro-credentialing, shifting careers was top of mind with our group. With these career transitions expected to become more frequent, more common, thinking about upskilling, uptraining, the use of simulation, the use of VR, and how does that translate into maintenance of certification and maintenance of competence? Certainly has the college rethinking its approach. And we have a responsibility to really support lifelong learning strategies of our fellows and our resident affiliates. And how will we do that in a healthcare system that is already under stress? I think this one is probably a no-brainer. AI will significantly impact early detection and prevention, and we certainly need to integrate that into all residency training and CPD across all specialties, not just cardiology, not just radiology. Psychiatry is some great use cases around AI when you talk to Brian Hodges. And then only a couple more slides. The college is a data-rich organization. We have a working group in place that I'll talk a little bit more about at the retreat that is thinking about governance of AI, how ChatGPT might work with item generation. And then here, Bertalan Mesco really impressed upon us, and we believe that AI will be the great democratizer. Patients will own, analyze, interpret, and bring their data more readily to the table. And it will really sort of flatten a little bit that hierarchy between healthcare provider and patient. And I'll just end on these final slides before I turn it over to Devin. What did our experts predict? Now going to become pervasive, where a patient is going to walk in and say, look, I think I'm having an arrhythmia. Let me show you my watch. Pull that out. Here we have Dr. Brad Wooter saying increasingly physicians are going to have to play the role around interpretation, steering, guidance, coaching. What that look like? And then anyone in AI may recognize this picture. This is Joshua Bengio, who we interviewed, and he said it could be that specialists are trained in such a way that they switch into another specialty if needed. And, you know, that was really remarkable for the Royal College to hear. How are we supporting this going forward? And do we have the capacity to do that? And just finally, this is not a one-shot deal. These recommendations have a very, limited shelf life. And we need to put systems in place that surveil and monitor the environment, people working with people like Devin and others to really think about what is emerging. And I will say, again, ChatGPT doesn't even appear in our task force report. So we're reconvening and thinking about what happens next, and how does this impact training and supporting our fellows. So I'll turn it over.
The landscape of how we invest in medicine and healthcare, and the decisions that your team is going to make will ripple for many years, right? For a few decades. So it's such an important topic. Just give me a quick moment here. I'm just going to switch my slides around. How's that looking? We're good? Yeah, perfect. Okay, so thanks again for the invite to come out and chat. Excuse to come out to Calgary from Ontario and spend some time with such a great group. I'm really thrilled to be here. And my journey into artificial intelligence really started when I was an R2 pediatric resident. So I remember being in the Emerge. I was part of a Code Blue team, and an alarm going off early in the morning, and got called to the bedside. And as the junior member of the team, you're tasked with doing CPR. So on that patient chest, doing CPR, and I just remember feeling this kiddo slip away. We were just too late. Made it to the ICU, onto ECMO, but unfortunately this little kiddo passed away. And in the review of that case, it was identified that there were a lot of preventable factors that maybe could have changed, right? Things about if the family could have got to hospital a little bit earlier. Things about what if the wait in hospital wasn't as long? What if we got to that antibiotic dose faster? And I was angry. Like I was just so angry by the experience that it kind of put me into a bit of a spiral of like, I can't just, go into emergency medicine. I need to do something different. And I found AI. And I started to realize that machine learning can help us connect the dots between a lot of the different facets of problems in healthcare. Like some machine learning models actually transcends many of them, which I found really interesting. With EHRs emerging very quickly, machine learning, I realized, could actually help us make sense of this massive wave of data that was coming at us, right? It's going to be increasingly more difficult to keep up with that. And I loved how machine learning actually helps you transcend and break through the traditional silos in how we work, right? If you're going to get a project off the ground from a machine learning perspective in your cardiology department and deploy it, there are so many different areas of the hospital that need to work together to actually get that to production, that it naturally forces us to be really collaborative. And so I love that about machine learning. The other point to make is that this is just one small snapshot of a few months of emerging AI-based healthcare startups that are notable. And you can see across many different industries within healthcare, like imaging, drug discovery, predictive analytics, hospital decision support. There are a ton of products emerging. And so us as physicians, we're going to have to think through, how do we actually work with these types of products? Like, how are we actually going to be able to integrate those into our clinical practice? And there may be a period where it gets a bit overwhelming. And so AI literacy will be really important to help keep things safe. Now, as I was building the presentation, I went on to ChatGPT and I asked it the following question. I said, I would like to give you, so I'm talking to ChatGPT, I'd like to give you the opportunity to say something to a group of doctors, nurses, and healthcare workers who work in cardiology in Calgary, Alberta. What would you like to say to them? Who knows? Like, who knows what this thing's going to say? So it says, thank you for giving me this opportunity. Here's what I'd like to convey. To the esteemed team of doctors, nurses, and healthcare workers in cardiology in Calgary, Alberta. First and foremost, thank you. Your unwavering dedication, skill, and compassion do not go unnoticed. Day in and day out, you are on the front lines, making impactful decisions, providing care, and making sure your patients and their families receive the best treatment and support. Cardiology by nature delves into matters of the heart, both literally and metaphorically. You're tasked with navigating the intricacies of one of the most vital organs, and the ripple effect of your efforts extends beyond the confines of the hospital walls. Every patient you see, every procedure you perform, every late night, fellows and residents, every late night you endure holds the potential to add years, quality, and love to someone's life. This like blew my mind as I was getting this position. And what blew my mind about this was like the empathy and like the emotion it provoked. I started thinking, I was like post night shift and I got called in for backup all weekend. I was exhausted. And I started thinking like, I feel seen by this piece of technology, which is different, right? Like we think about, oh, but AI can't be empathetic. AI can't convey emotion. But in that moment, I felt somewhat emotional. Still wrapping my head around that. And so, this technology, to your point, is emerging, right? And evolving. And so I want to show you a bit of my own research in at Sick Kids to sort of prove to you like this is happening now. And so let's take this kiddo, he's at home, he's having tummy pain, and really he should be at school playing, having a great time. But he's not been at school for a couple of days. Mother here has to decide, am I bringing my kid to the emergency department? Does he actually have a meaningful problem? And the spoiler alert here is the kid has appendicitis. Okay. So what happens? He comes into our emergency department and he goes through the same workflow that we know we're going to see, right? Gets triaged, data is put into our electronic health record system, and then they wait for overnight. The other day, my wait times got up to like 4 to 6 hours. I felt a little bad about that. So 4 to 6 hours waiting there, right? And then I'm going to see him and say, let's get an abdominal ultrasound for ruling out appendicitis. And that might take me, maybe another 2 hours or so. And if the hospital's really busy, that may take even longer, right? Then we get to the diagnosis. I have to call general surgery. We have to prep the OR. And there's this chain of things that occurs with a lot of time spent waiting. The question is, if you ask this little 8-year-old guy, or you ask the parent or the triage nurse, what their concern is, even right here, when we first captured the data, the concern was, does my child have appendicitis? Yes or no? So we started to wonder, like, could we actually just get the order in right at time 0 when the patient arrives? Like, could we predict that this patient would have appendicitis? Because we're all thinking it, right? Kids Googling, maybe talking to ChatGPT, right? And ChatGPT is like, dude, you have appendicitis. Go to get your mom to go to the emergency department, right? So everyone is thinking that right now. And, I already sort of went over, like, who are all the stakeholders here? We've got the ultrasound techs, we've got the general surgeons, we've got booking the OR. If I place this order in this linear fashion, probably 8 hours passes and then the order goes in. Ultrasound techs are starting to go home. They're paring down because we're getting into the evening. Our resources in the hospital are starting to pare down despite this kid coming 8 hours earlier. Could we do something faster? That was our question. So what did we do? We took all the data available at triage, and I'm going to deep dive into this during the workshop, and I'm so excited to do that with you guys. But we took all this data, we plugged it into 3 very common types of machine learning models. And again, we'll demystify these models a bit later today. You could think of these models as 3 different cars, if you will. We're trying to get to the destination of predicting, does the patient have appendicitis, yes or no? And we can take 3 different cars to get there, or 3 different modes of transportation. That's all this is. And what we found was that actually we could predict if this patient had appendicitis with just the triage data. This is an area under the receiver operator curve. The results look pretty good here. And if you've never seen one, we're going to also decompose this in the workshop. But what it's showing us is that we actually have a model here that can have a good true positive rate with a low false positive rate. So we can actually have a pretty decent precision at predicting, does this patient have appendicitis? And at this threshold where we're actually operating the model, we could probably save 167 minutes. And that was actually a calculation done when our volumes in at Sick Kids were actually a bit lower, right? So even right now, when my wait times are 4, 6, 8 hours, this gets, a lot higher, a lot more value add to something like this. What was also really interesting is that then I thought, okay, appendicitis is kind of hard. What if we choose easier things to predict? Like, does the patient have a UTI or automate ordering a urine test? Does the patient need an ECG? Does the patient need an X-ray for an arm or a chest X-ray for pneumonia? Simple thing, testicular ultrasound for rule out torsion, ovarian torsion, things like that. And we actually found that this method could scale to many of these sort of, I call it low hanging fruit use cases. In the adult world, you'll often have medical directives. So I call this machine learning medical directives because nurses have medical directives to just put a lot of these tests in, but we're a little bit cautious about over ordering in kids. I mean, we're not just going to do blood work on every kid that comes in if they're complaining of chest pain, for example, like we might in the adult world. And so this machine learning algorithm allows us to add a bit of precision. But you can imagine in the adult space, you don't automate ordering an ultrasound, right? So there's still utility there in an adult space. Or what about the idea of using healthcare resources in a bit of a more precise way, right? We've got nursing shortages, we've got other human resource shortages in emergency departments and hospitals. What if we didn't need to do the blood work for all of those people and we diverted a bit of those resources in a more precise way? Cost savings and maybe actually, better throughput through an emergency department. So there's application to this idea of getting a machine learning model to be a bit more precise in the way we provision medical directives right at triage. And so that's what we're doing here at Sick Kids. And so what ends up happening is we then have to think through how do we deploy this into practice? And some cool principles we'll talk about in the workshop on how to actually conceptualize taking a machine learning model and integrating them into your workflows, because I'm hoping it will spark some creative ideas amongst your group around what you might use in your own division. But what we realized here is we needed to have a model that could have really high precision. So what does that mean? That means that you have very, very low false positives. Because if I start automating ordering all these ultrasound tests and I have a whole bunch of false positives, who's going to be on the hit list of the radiology department? It's me, right? The radiology mafia is what I call it at Sick. It's going to come right after me and take me out. So we really can't have false positives. But when you're building a system where you want your false positives to be low, there's a consequence to that. There's a trade-off. The trade-off is you're going to miss a whole bunch of the true positive cases. Now, how do we rectify that? Well, you rectify that by thinking through, well, what's actually going to happen on the ground? So kiddo comes in now in this new workflow, data gets put into the EHR just like it was before. If the model fires and predicts with high precision, low false positives that we need this test, great. Why don't we just order the test and fast track that kiddo to the ultrasound while they're waiting, just like a medical directive? But if the model says, don't think there's appendicitis, doesn't order the ultrasound, we can't send that patient home, right? Because we know we're going to miss a bunch of the cases. So we're just going to put that kiddo into the waiting room and they will go through the normal standard of care workflow. The hypothesis here is that if we have a whole bunch of things being automated here and we're able to get kids out of the emergency department faster, might the top workflow, which is the standard of care, might that actually also move faster? We don't know. You can simulate this, and my team has done that, where we're simulating like how do the bottlenecks shift in the workflow based on this type of intervention. But the reality is we just have to do it and see what happens. And so in order to do that, we need to learn how to critically appraise a model and how to integrate them into human workflow. And this idea around the critical appraisal of a model we'll also talk about in the workshop. It's going to be great. But what about bias, equity, and fairness? So let's think about a bias assessment here. What if we have a model and it has a whole bunch of false positives, or maybe it's missing a bunch of cases as well. And these bars represent different subgroups of patients. What if most of the error happens in this population of people? You might actually, on a high level, look at your model performance and say, wow, it's got like a 92% success rate or whatever we want, whatever statistical metric you want to do, sounds good. On a global picture, it might sound amazing. But then if you actually do the subgroup analysis, you might find that like, but wait a minute, there's one group of people who bear the burden of that error. And what if that's related to age? There's ways we can get around that. Gender, maybe we can get around that. What if it's related to race? What if there's like a particular population that's underrepresented and the model gets confused? And this isn't a unique problem in healthcare. So these are some examples. Well, I guess this is a healthcare example, but these are some examples of like big teams, big successful teams who've put things into production and it's gone wrong, right? So this here was a project where they were looking to predict who might need critical care resources. And they looked at a bunch of the EHR data, and then they predicted this outcome of needing to go to critical care, right? But then what ended up happening is the model ended up being biased because people who were Black in their patient population didn't have the opportunity to spend healthcare dollars and make it to critical care. So the people building this model, they're obviously not building something to be biased, but there is a bias in our data. There's a bias in our systems and how models learn. So we have to be hyper aware of that. How do you counteract that? You do the bias assessments before you deploy widely. Amazon, massive AI company, was using AI to facilitate hiring, and they systematically were taking females and moving them lower on their interview list. This was a huge scandal. Think of all the opportunity that Amazon lost out on there, right? And how much harm they did to people's careers. Even things like Google and the Amazon Echo, the smart speakers, right? If we're using smart speakers as part of like an interface or a technology that we're deploying into parents' homes or something cool like that, you can think of some cool ideas. If you have an accent, here's the performance of those speakers, right? If you have a Chinese accent or a Spanish accent, an Indian accent, right? The speaker's ability to then understand and translate that into like data for you, the accuracy starts to go down. So your healthcare tool, if it's dependent on this, you're going to create a bias, right? You have to be aware of that. This was another really great example of the point I'm trying to make. It's a project called Gender Shades, and they were looking at also big companies like Microsoft, IBM, using facial recognition for different technology applications. And when you looked at darker skin subjects and lighter skin subjects, looked okay. I mean, well, I don't know. This is another question. Is that okay? I mean, I just see green bars. So obviously whoever created this thinks the difference is okay, that it's okay that there's a 12% difference, a 19% difference. They, some value judgment was put there to say it was okay. Who decides what that threshold is? Is it okay that like it's 5%, 10%? But anyways, let's dive deeper, right? Let's do a proper subgroup analysis. And then the story starts to unfold. And you start to realize if you're of a darker skin and you're female, the model completely breaks down. Why? Because this group maybe is underrepresented in the training data, right? And you can think of all the societal issues that maybe influence someone's ability to even participate in a research study or in some sort of like data gathering intervention. This population wasn't captured, not modeled properly, and now therefore get all the errors, right? Wouldn't have known if you didn't look deeper. So we have across Canada one of the most diverse populations in the world. But the problem that I'm running into in Toronto is that there's no ethnicity data. So I can't even begin to do the subgroup analysis to understand, are my models being fair or not? And this is like, I've been beating this drum for a while. The technical piece to my deployment of AI solved. It's this that I need to work on and figure out how to do. The other quick piece, I'm going to end in the next sort of like 90 seconds or so. The other piece is around, this AI augmented workflow looks great. But what would be even better is if we zoomed out a little bit and thought about the patient's perspective. We surveyed patients and they said they want this in the home. That sounds great. I'm using triage data. I could see how data from triage will be very similar to data in the home. It's a couple vital signs and just a little snippet of text, right? We should be able to capture that. And then think of how cool it would be if from the home, if people seem safe, they go straight to ultrasound, or they go straight to an echo, or they go straight to some sort of ECG or intervention, right? Skipping the whole long wait altogether. That would be a dramatic shift in how we provision, acute care. But what if you need access to certain hardware, right? For example, this Owl sock that some parents have is $400, right? These smartwatches, they're expensive. Access to smartphones are expensive, although survey says that most people, regardless of their economic status, buy a smartphone, which is interesting. But access to these auxiliary technologies, is important. So you would get left out if you couldn't afford that, right? And what about access to internet? Here's an internet serviceability map that shows that all of these areas with satellite don't have proper like high-speed broadband internet access. At least it's very difficult to get. And there's cool Starlink stuff that we're seeing out there that are going to bring high-speed internet. And I think this technology is cool, but it's expensive. $140 a month makes you think twice, right? And when your Netflix is loading and you get really pissed off about it, imagine it's your healthcare loading, healthcare for your parent, healthcare for your child, and you're sitting there with your crappy connection, trying to participate in AI and digital health, but it's just spiraling. Multidisciplinary teams in AI must include people with EDI expertise, design thinking expertise, because AI has to be for everyone. And so as we build these incredible technologies in your division and across the country, we have to constantly think about how do we stay inclusive to make sure we bring everyone along the journey and we don't accidentally widen the healthcare gap. Thank you so much for the opportunity to chat.
Thank you both very much for your presentations. But I have a question for you, Devin. If you ask GPT chat for the same letter for U of T or U of O, would we see the same response? Oh. The question I asked Devin is, if he asked GPT chat to provide the same question with respect to U of T or U of O, would it give the same response? Because that could give me a clue when I'm looking at the CARMS application. If I get similar letters from applicants or from their referees, they might be in trouble.
It's for cardiologists in Toronto.
Is it still bringing love? That's what I want to know.
There's no love in Toronto. So here's a message tailored to cardiologists in Toronto. To the distinguished team of cardiologists and heart care professionals in Toronto. So they're still distinguished. Your commitment to the field of cardiology, nestled in the heart of one of Canada's most vibrant cities, is truly commendable. So I think GPT just kind of dissed Calgary there. The heartbeat of Toronto resonates through its people, and your dedication ensures that this rhythm remains strong and healthy. Wow. Navigating the complexities of the heart requires not just medical expertise, but also a touch of empathy and understanding. Your relentless pursuit of excellence, from the operating theaters to the consultation rooms, helps ensure that countless individuals lead fulfilling, active lives. With every diagnosis made, procedure performed, and recovery overseen, you instill hope and grant the gift of time.
No love.
Similar kind of themes, though, coming up there.
But it does appear to be more Toronto-centric, rather than the center of the universe.
Yeah, and
It seemed to
I
have
blame you,
Toronto
Devin.
at the center of the universe.
yeah.
Do you want us to go up there for a question?
Oh, sure, yeah.
Sure. Okay, let me check if there's any questions online here. Kelly, can you see?
There's no questions in the chat.
Okay, so if someone wants to put questions in the chat, or if they just want to, we can then open it up so that they can ask questions. Please do so. Okay.
Getting to the very heart of the idea of using AI essentially for triage, right? Triage at different stages. Where is, and you alluded to this in your talk, where is the difference between using AI to make a decision about ordering that ultrasound versus having the triage nurse make that decision? Where is the value add of AI over downloading them?
Yeah, no, it's a great question. And so one of the interesting things that we see when we audit the actual execution of the medical directives in our emergency department is the busier the emergency department gets and the busier that triage line gets, you start to see that the orders stop going in because the priority has to be to triage those patients. That's the biggest risk for an ED, is when someone has arrived, but we've not yet triaged them. So you don't know what's sitting there in your waiting room. And so at the very time when you actually need your system of efficiency, which is the medical directive, to scale up, it starts to break down. So there's that part there where an AI-based technology won't falter in that scenario. The other piece too is around usually, you know, a triage nurse is going to have like X number of medical directives, easy access, because there's, you know, specific inclusion criteria, exclusion criteria. But what if you scaled that out to like 100 different ones? And they each had specific, you know, if this, you can do it, if not, you can't. It would take a triage nurse a bunch of time to really have that down, right? With like when to order things, when not. So that actually slows down the triage flow as well. And then there's this idea of, you know, like if you're needing to have like a really mature triage nurse flowing quickly, but also grappling with many, many medical directives, and then they leave, you're having to retrain these new nurses again. So you start to get this up and down variability in the quality of how those medical directives are being placed, which wouldn't happen with an AI system. And I'll tell you, like the evil genius part of why we picked triage though, was because we're thinking about the translation to the home, right? So we think that there's really similar mirroring of data that will be captured in the home environment. And so we're really actually using that specific data, less so to say, let's add capacity to nurses, although that's what we're doing, but more interested in, can we really rethink the way patients arrive to our department by translating these technologies into their home? And that's where we discover and unearth all of these ethical and access dilemmas, which I don't have answers for yet.
Just wondering at a sort of a higher systems level, how your interactions with the kind of healthcare providers have gone in terms of obtaining data. Because I mean, all the big healthcare units across the country, and certainly us going on Connect Care with very rich data events, they must be bombarded with requests from AI type companies to get access to the data, because that training data is extremely valuable. It's your lifeblood for your systems.
Yeah.
How do they manage who gets access, how it's controlled, and curation of the data, and ensuring it's not getting used for purposes that are not going to be beneficial to them? And because that's a kind of complex piece as well.
Yeah, totally. And so the data access piece is complicated, and there's two sort of lenses to it. You kind of alluded to, if you're a vendor and a third-party solution provider coming in and then innovating, versus for this particular project, that's with me with my like AI research hat on. So I'm like, it's an internal research project at SickKids. And so in that instance, we leaned on the REB, and at SickKids, we have like a 3-staged REB that we could talk about in the workshop, but it's basically, it's focused on like enabling AI project work. And so it has all of these like sort of governance best practices, the data has to here, only these type of people can access it. This is what you're going to use it for. And so it puts a lot of controls in place, because, you know, this data set that we're training these models on actually arrives in real time. And the retrospective database is growing like minute by minute, because we're capturing and building this record of research data, you know, with every patient that comes through. So the models are constantly going back and learning. And so it is quite risky. You know, the data set probably has, you know, over 300,000 to 500,000 patient records. And so by risky, I mean that if you were to do this willy-nilly and not think about all of the governance, and is the data sitting in an encrypted space, and is it staying on-prem servers, and how are you managing that risk, you could create like an issue. And so to get this project off the ground, it took me 4.5 years from the idea when we started, because we didn't have those systems in place. And so it was the hospital using this as a use case to build out all of the governance pieces, what the new REB would look like, what would deployment look like, how do you decide when it's safe to deploy. So the AI in Medicine initiative at SickKids tackled all of that. So it was a lot of work. But you can liberate the data with good governance, right? And it can drive like really impactful solutions for patients. And I think it is, like, to Tanya's point, like the Royal College and data literacy as a pedal, right? I think part of us being advocates as the modern physician is around how do we liberate that data in a way that's respectful for patient privacy and cyber and safety, but we advocate for its use so that we can become data literate, but we can also have that impact of data translate to better patient care outcomes. Yeah.
Just to add something, just having given present,
It's actually a question for Devin that I kind of know the answer to, but I think it's the group is just the impact of the false positives. This is what I've heard from some physicians that say, you know, worry about the over-reliance on the model when you start to say that this has got high precision. Just talk to us a little bit about what's going on in your group and how that piece has been impacted. Like that point where you say, I'm going against the model, are we at risk of losing our instincts?
So in this use case, what's happening is the model is automating an order, right? And so the false positive in that case, you know, just might be annoying to the physician, because what if something incidental comes, the physician's like, I never would have ordered this. And now we've all had that where we've like ordered a test and we were kind of, and then we ordered, and then we got the result, like, wish I didn't order this test because it was borderline to begin with, probably shouldn't have done it, right? And so there may be instances where that arises for this particular use case. But I think that the descaling, right? Let's say that AI should start reading our x-rays. We have all these discrepancies in emergency medicine. AI should start reading our x-rays, maybe supporting the emerge physician reading ECGs. So there's less discrepancies from when you guys do your secondary review, right? Of the ECGs that get ordered. I could see how I would become descaled in that process, especially in a process where it was an automated pipeline, where a patient arrives, and for efficiency purposes, I just order a chest x-ray and then the patient disappears and goes into an automated pipeline where an algorithm says, yes, you've got pneumonia, looks at your vital signs, everything is fine. Maybe a physician assistant or an algorithm even then provisions the diagnosis and gets you your prescription, you go for pneumonia, right? I will be then disconnected from the technology and I would be at risk of descaling. So that's going to be an interesting thing on how we think of how we tackle it. Because what, you know, the counter argument is that will elevate me to provide a whole different level of like human focused care, right? But when those systems go down, is it going to be one day, like, let's jump like 30 years, 40, and they're going to be like, where's Devin, the old guy who's still here, who once looked at chest x-rays, right? And no one has looked at a chest x-ray. Like, might that day actually occur? Potentially, right? So we have to think through how we mitigate that. And it's
The only thing I would add to that is this is where the conversation at the task force
Heard, which was, there may be this risk of de-skilling, but it's actually the new skills that we'll have to have, so.
Yeah.
I want to switch to the patient point of view. Let's say I've seen a patient in clinic and I've given them a diagnosis and I've read some recommendations and they come back to see me, or they come back with a phone call and say, hey, I went onto this AI platform and they gave me something different. So how do you deal with that? How do you educate your patients as to a reliable platform that they should go to?
I see it a little bit as like with Google and internet, and like a similar type of like friction that occurred. And I see it being, in your example, being a bit similar like that. But the interesting piece will be, like, as the physician, your ability to critically appraise the resource might be challenging. So for example, patient comes in, they show you, oh, they have a printout from this website. I saw this, shouldn't I be on this medication? You look at the website and you know what's credible, what's not, and you can steer your conversation in a way. And usually what I do for families is I'm like, you know, oh, it's great that you're so engaged in your care. Like, I spin it into a positive and then I teach them about whatever. But what about some AI model that you have no insight onto, like the performance, the validation, like it's going to be, and even if the method is something that's pretty like novel and cutting edge, like how are you as the physician to then like actually question yourself? Because you should, if a patient comes up with something to do, you should take a moment, question myself, is this the right thing? Right? But how are you going to do that? And so that gets into this idea of something called model facts. And so there was a group that published, I think he's at Duke, Mark Sendak, who then published this paper in Nature. And it was this idea that models that actually go into production and that are regulated by Health Canada and approved for use should have like a model facts label, almost like a drug label, right? So that there's some sort of standardized way that as physicians, you can look at something and then quickly orient to its efficacy and its generalizability to that patient, right? Because what if that model actually has a big error bar, right? And that patient falls into the subpopulation where all those mistakes are being made. And that's why the recommendation is being given. We need transparency on how these models are going to perform to enable you as the clinician in that engagement to then be able to critically appraise and support your patient with making the right decision. That's going to be huge. And so who enforces that? Is it the innovator? So if I put my startup hat on, if I'm innovating and I'm leading a lot of these initiatives, I'm going to just do that because I think it's going to give me a competitive edge in the marketplace. I think it'll make it easier for me to sell things to hospitals, right? But if that's not mandated, right? You're then gonna have this like piecemeal stuff, and you're not gonna know what's legit, what's not legit. And so does Health Canada do it?
Surprisingly, a lot of people have asked the college to
Yeah.
get into this space. I mean,
And just commenting that a lot of physicians have come or written the college and asking us to get into this space. I'm not sure this is the space we'll be going, but did you want to mention our scoping review?
Yeah.
It's really looking
you
at
go for
this. No, go for it.
Well, I mean, it's your methodology. So it's mostly Tanya. And essentially, what we did is we did our scoping review to look at what were the key issues that were being that were emerging in literature between the intersection of health law, AI, and things like safety, risk, things like that. And you'll see in the workshop, I show a slide where you'll see 2016, it just boomed. Physicians are writing about privacy issues, medical, legal. They're writing about this exact question. If I say that we should do A, but the model said B, and then the patient had harm, and really we should have done B, we should have did what the model said, is the physician liable? But then how do you hold a physician liable when they can't even appraise the very thing that, the very tool that's there? So we're gonna enter into this really interesting space.
well, the argument is creeping up that it's like any other.
The argument for some is that the technology is like any other technology in a hospital and that there's error around that. So we'll talk about that more deeply this afternoon.
What is the role of AI in CME?
The role of AI in CME. I don't know what the role of AI in CME is going to be, but I certainly know that CME and CPD is going to be focused on AI. I think I touched on this a little bit. I can speak to the college's directive that we're now really focusing on how do we create a system of education. It's so hard to not see people online. A system of education that not only involves accreditation, exams, our MOC, but recognizing that it can't be education only in one spot. So how AI will affect CME as a field, I'm not sure, but I certainly know that this will be a focus of the college in terms of CPD and what we offer in terms of education.
To see like, what if you took all your past like CME content and then you said to an AI tool, like generate another module or generate tag for, that'll be interesting too. Like, does it actually expand? It'll be interesting to see how we start to use the tool.
Not something I can predict, but we're playing around in this space in research for sure. And I'll be talking about this afternoon, but we're doing a panel with a researcher who just wrote, she's a rhetorician, and how she used ChatGPT to support writing for research and thinking about that. So if you're interested in that,
Okay, we're getting close to the top of the hour, and unless there's any burning questions, we'll stop there, and we'll thank our guests very, very much for coming and joining us today and delving into this a little bit more.
Okay.